Sydndrome. Okay, so this is basically a constellation of metabolic abnormalities. So this is not a single disease, this is a syndrome where there would be different abnormalities, and if you cluster them together, you label them as metabolic syndrome. And the reason that you would like to find, actively discover this in your patients is because this confers a higher cardiovascular disease risk and a risk of diabetes mellitus. So if there is diabetes mellitus, there would always be a higher cardiovascular risk. Hello, can you hear me? So these are the alternative names that have been given since it first was described by Dr. Riemann in one of his patent lectures in 1988, and if you search the literature, you will find these alternate names. So it can be called as syndrome X, insulin resistance syndrome, the deadly quartet, and the Riemann syndrome. Riemann is after the scientists who first labeled it as metabolic syndrome. So what are the major features of metabolic syndrome? Any volunteers? Great. So you already know everything. I don't have to work very hard for this part. Okay, so all of these are basically components of metabolic syndrome. And you know that as the prevalence increases, the prevalence will increase with age, and then the industrialization and globalization is something which is, urbanization is something which is pretty main, because we know that the prevalence of obesity is rising, and as obesity is rising, metabolic syndrome is also increasing. And among is different components, the increased waist circumference is more common in women, while a high triglyceride level and hypertension is more likely to be found in men. So this is a slight variation based upon gender, upon the components of metabolic syndrome. And then, so what is the burden of the disease? So it's understandable that metabolic syndrome is far more commoner than hypertension, than cardiovascular disease or metabolic syndrome. So you can see that 20 to 25% of the world's adult population has metabolic syndrome. And the implication is that because they would be having a higher relative risk of developing diabetes mellitus, which is around more than 2, and a high risk of developing cardiovascular disease, which is around more than 1.5 relative risk. And they are twice likely to die as compared to their non-metabolic syndrome counterparts, and 3 times more likely to have a heart attack or a stroke, and 5 times more likely to develop type 2 diabetes mellitus. So we have to intervene really early to avoid or prevent or at least control these different components. So another quiz. What are the various risk factors for metabolic syndrome?
Dr. Aisha, could you ask this is fine.
Okay, so see, congenital heart disease is not part of metabolic syndrome. So this is what we are. We love to eat, isn't it? So if you just imagine, we relate everything with food. If a child passes his exam, we want a treat from that child. If there is a wedding, we would just comment on what kind of food was served at the wedding. Even we do not spare deaths, isn't it? If someone goes to a death, kol pe gaye hain, khana tha ke nahi tha aur kaisa tha. So we love to eat. This is so food has become an entertainment for us. It's a source of pleasure for us, which should not actually have had happened, because food is a necessity of the body, and if we make it a pleasure, then we overeat. So you can see all these fried items, the size of this thing, I don't even know what is this name, and jalebi. And so during Ramadan, jalebi, and this is all the lavish food cuisine that we have in Pakistan, isn't it? And then we blame it that on we just have gone through Bakra Eid, and this is what has happened to most of the people in Pakistan. Okay, so and then there's also fast foods coming in. So this is urbanization. So we cannot only blame urbanization to the metabolic syndrome. You can see that our own cuisine was very rich, and then we have on top of it this fat burger. Even the name says it's fat burger. And then all these sweets. Even if you are looking at this, I start to water my mouth, isn't it? So it's very difficult to just restrain yourself to eat in a limited amount. And then, so you can see shadi. And I really think that motorcycles, these bikers should be really tough and to bear such a weight. And even our police is not spared from that increased weight circumference. So these are the risk factors of developing metabolic syndrome. We know that central obesity is a major risk factor, and central obesity means that there would be more of visceral fat. Sedentary lifestyle. So with urbanization, there is more of sedentary lifestyle. How many of us have gone for an exercise this morning? Anyone done an exercise this morning? So among all this, only 3 people have 3 or 4 have risen their hands, which means that even among us healthcare professionals, we might not be able to find enough time to exercise, and we are trying our patients to do that. So aging, because we know that the expected age, the life expectation has increased over last few decades, and with aging comes the risk of metabolic syndrome, diabetes, hypertension, and ischemic heart disease. 75% of the type 2 diabetics or even those who have got pre-diabetes would have metabolic syndrome, and 50% of the coronary heart disease patients have metabolic syndrome, and about 1/3 of the metabolic syndrome patients would be having premature coronary artery disease. And then there are different forms of lipodystrophies which are both genetic and acquired, which have severe insulin resistance and can impose a risk to develop metabolic syndrome. So what is this? This thing. Great. And this is called as acanthosis nigricans. And what are these? These spots. These pedunculated things. So these are skin tags basically, and skin tags again are part of insulin resistance. So even if, by just looking at their necks, you can see that they have insulin resistance and are at increased risk of whatever disease is associated with it. So acanthosis nigricans is a feature of insulin resistance, but can occur, you can see it in polycystic ovarian syndrome as well, because in PCOS there is insulin resistance. So clinical features. When the patient comes to your clinic, that the patient would not be coming with a diagnosis of metabolic syndrome or even with obesity. How many of you come across patients who come solely for obesity? Doctor Sahab, mera wazan badha hua hai. Rare. So this is really rare. They would be coming for other things, like maybe a hypothyroid patient is coming to a clinic and you have just seen that the patient has a higher BMI. And maybe then if you measure their waist circumference is high. Similarly, patients would be coming in your hypertension clinics, in your diabetes clinics, young girls with polycystic ovarian syndrome. So you are the ones who would be actively thinking that they might be having metabolic syndrome, and then working them up with a limited workup at least to look for different components of the syndrome. So on examination, you know that there would be increased waist circumference. Higher blood pressure is also a part of it. Lipoatrophy can be seen if there is congenital lipodystrophy syndrome. And then, as we have seen in our last slide, acanthosis nigricans and skin tags. These should alert research for other abnormalities. So metabolic syndrome is associated with increased risk of all except non-alcoholic. It's not associated with non-alcoholic fatty liver disease. Hi. Okay. So hypothyroidism, NASH is a component of metabolic. So it's a comorbid condition of metabolic syndrome. So hypothyroidism per se is not a feature of metabolic syndrome or a disease associated with metabolic syndrome. So these are the other conditions that are associated. We have discussed about cardiovascular disease. So there's an increased risk of new onset cardiovascular disease, ischemic stroke, and even peripheral vascular disease, type 2 diabetes mellitus, NAFLD or NASH, so non-alcoholic fatty liver disease or non-alcoholic steatohepatitis. And this is something that you can use as a educational tool for your patients, because NASH would damage the liver in the same way like Hep B or C does. So cirrhosis can occur just because of NASH, and maybe to protect their livers they would be more compliant with their lifestyle advice. Hyperuricemia is also another associated condition of metabolic syndrome. The prevalence of polycystic ovarian syndrome is around 40 to 50% in young women who have metabolic syndrome. And then obstructive sleep apnea, and you know that obstructive sleep apnea itself then promotes insulin resistance. And if you have counseled these patients and they can apply CPAP at least while they are sleeping during night, it really improves their insulin resistance and helps them reduce weight. And this actually doesn't end over here. There are at least other two conditions that are important components part of metabolic syndrome. One is the hypogonadism and sexual dysfunction. So there is a morbid obesity related associated hypogonadism, and the other is an increased risk of cancer. So you know that with insulin resistance and metabolic syndrome, the incidence of different cancers like breast, endometrial, colorectal cancers increase as well. Okay, so this is a multifaceted syndrome. You can see that there would be inflammatory markers. These patients have higher microalbuminuria, higher blood pressure, abnormal lipid levels, high blood glucose level, obesity, and then the risk of all these. And depression, of course, is a very important associated condition, and it can lead to depression, and depression can lead to metabolic syndrome. So another quiz. All of the following parameters are included in the diagnostic criteria of metabolic syndrome except LDL is not the diagnostic criteria of metabolic syndrome. Excellent. So according to IDF criteria, this is the so if you go through the literature of metabolic syndrome, you'll find that there were different criteria being advocated since its conception, and right now the International Diabetes Federation criteria, and then following that there was another harmonization definition which have been more used in clinical practice. And IDF criteria is more for a clinician because it has the clinical parameters and certain lab parameters that could be easily done. So I think most of you are using the IDF criteria for diagnosing metabolic syndrome. So which is the odd one out among these? So triglycerides less than 150. It's not less than 150. It's basically more than 150. So how would you measure waist circumference? So this is the method. Remember that if your patient's body mass index is more than 30, then invariably their waist circumference would be higher than that required to diagnose metabolic syndrome. But for all others, even with those who have got maybe normal body mass index, their waist circumference could be fulfilling the criteria of diagnosis. And the method to do is just like right above the iliac crest, and then you have to place the measuring tape in a horizontal plane around the abdomen at the iliac crest, and the tape should snug and does not compress the skin. And when the patient is at the end of normal expiration, you measure this waist circumference. So these parameters are for Caucasians. I will come to the South Asian criteria in my next slide. So what is the pathophysiology associated with the pathogenesis of metabolic syndrome? What is the main insulin resistance? Yes, so we have already been through insulin resistance, and this leads to metabolic syndrome. So by looking at this, I don't think that I'm a proponent of Darwin. I don't believe in Darwin at all, but at least this part of evolution, which has occurred from this stage to this is happening right in front of our eyes. We like to be sedentary, we have remote controls in our hands, and there's TV with all those more than 100 plus channels, and thinking about food. and look at this waist circumference and obesity. So this is what the urbanization and modern world is giving to human nation. So the pathogenesis is increased insulin resistance. There would be more of visceral fat leading to increased waist circumference, dyslipidemia, glucose intolerance, hypertension, and decreased adiponectin levels. And there are various cytokines that are playing role in this pathogenesis, which are different kinds of interleukins, resistance, TNF alpha, and C-reactive proteins. And adiponectin, which is an anti-inflammatory cytokine, is basically reduced. So the protective things are getting lesser. Like we know that HDL is low in these patients, and the things which are promoting inflammation are higher in these patients. So if you look at the pathogenesis in much of detail, you can see that an individual has to be really genetically predisposed to develop such things. And then there is a role of fetal programming, and there is a lot of interest and research going into this part of the pathogenetic pathway, where you know that maternal undernutrition and maternal overnutrition both lead to fetal programming in a way that if that fetus is then in later life exposed to higher dietary intake and reduced physical activity, that person is at risk to develop insulin resistance, visceral obesity, hypothalamic pituitary adrenal axis dysregulation, and an atherogenic dyslipidemia, which is characterized by low HDL, high LDL, and high triglyceride levels. And all these syndromes, all these hormones, hypercortisolism, and these deficiency of growth hormone or hypogonadism all promote obesity. And then there are different cytokines which we have already discussed in our previous slide. And then these two things, insulin resistance and hyperinsulinemia, would promote these procoagulants and pro-inflammatory markers and alter the hemodynamics in a way that hypertension, the body is more prone to retain sodium and elevated sympathetic activity, and these combined lead to coronary artery disease. And this is a more complex pathway that is showing the same things. You can see that through insulin resistance at different levels, the inflammatory cytokines are getting elevated, the protective like adiponectin is going down, and you can see the hypertension, low HDL levels, and high triglycerides level coming into play. So we know that prevalence of insulin resistance increases with increasing body mass index, and you can see that for each body mass index category, the level of insulin resistance and hyperinsulinemia is rising progressively. So for anybody who has got a BMI of more than 35, there is more than 50% prevalence of insulin resistance in such individuals. And this is important to consider, that if they will reduce weight, the insulin resistance will lessen and things will improve. Okay, so this is again the role of insulin resistance that leads to all components of metabolic syndrome and its associated conditions. So we worry about global warming, bird flu, dengue fever. No one is worrying about this 400 kg gorilla sitting in the room. So we have to really think hard about this obesity pandemic that is happening. Although it's an NCD, non-communicable disease, but the way it is impacting the human health is something to be considered by authorities. And I don't know how much, how sincere their efforts would be, because you know the food industry is a multi-billion-dollar industry, and if you look at the pharmaceutical industry, which is making all this anti-diabetic drugs and antihypertensive, this is again a multi-million-dollar industry. So are we really doing enough to prevent obesity, to just make our food industry and the pharmaceutical industry go against us?
We have
to prescribe, because by the time the patient reaches us, yes, definitely. Definitely.
Youngsters suffer.
The patients suffer, but we have to intervene at a very early stage, not at a stage when the diseases have developed. The doctor would be prescribing some medicine or other, but if we work at a root level at prevention, that is something which the governments and policymakers have to really think hard about. We are not, there are not many doctors, there are not enough resources to handle all this epidemic of obesity, type 2 diabetes and cardiovascular disease, isn't it? Okay, so which of the following conditions is not associated with metabolic syndrome? Polycystic kidney disease is not part of metabolic syndrome. Okay, so this is the IDF definition. For IDF definition of metabolic syndrome, the waist circumference is a must. So waist circumference has to be high combined with any two of these four. So you can look at the, already know raised triglycerides of more than or equal to 150, or if the patient is already on a specific treatment for this lipid abnormality, a reduced HDL cholesterol which is less than 40 in males and less than 50 in females, or if the patient is on specific treatment for this lipid abnormality, a raised blood pressure. So if the patient's blood pressure is 130 by 85, or treatment for a previously already diagnosed hypertension, and a raised fasting plasma glucose which is 100 or more, or already previously diagnosed as type 2 diabetes or even pre-diabetes, that would qualify for these factors. And what is the waist circumference? So waist circumference criteria are different for different populations in the world, because South Asians are inherently insulin resistant at same kind of BMI and at the same kind of waist circumference like their European counterparts. We are at more risk to develop insulin resistance, type 2 diabetes and cardiovascular disease. So this is the cutoff that you have to just remember. So in women it's 80 and in men the cutoff is 90. So anything above that or equal to that qualifies for a higher waist circumference. So how to diagnose? As we have already discussed that the patient would not tell us that I have got metabolic syndrome. We have to actively look for that. So look for the IDF criteria in your patients, look for any symptoms of obstructive sleep apnea, and if that is present, refer them to your pulmonology colleagues to get their sleep studies done and CPAP applied. Look for the features of PCOS in your premenopausal women. Ask for a family history of type 2 diabetes and cardiovascular disease. Measure their waist and blood pressures. And for investigations, a fasting lipid profile and an oral glucose tolerance test, and at least a urinary microalbumin, LFTs for NAFLD are important. And if there are any features of PCOS or hypogonadism, then you can work them up accordingly. But at least a fasting lipid profile, a glucose tolerance test, and LFT, even if you do an SGPT, that would suffice. You can skip these. Fibrinogen is not available in our routine practice, but high sensitivity CRP might not be needed always in your patients. Uric acid, at least you can get it done if there are any features of hyperuricemia, and urinary microalbumin to look for any microproteins leaking into the urine even at the stage of metabolic syndrome. So you can see that the incidence of chronic kidney disease and microalbuminuria increases with the number of risk factors a patient has. So if the patient has no risk factors, you can see that it's well below 5%. And as the different risk factors of metabolic syndrome keep on rising, the prevalence of chronic kidney disease and microalbuminuria rises as well. And then cardiovascular morbidity and mortality. So if the patient is not having metabolic syndrome, the risk of coronary heart rate disease, MI, and stroke all are less than 5% prevalence. But if these components are present, you can see that there's a sharp rise in coronary artery disease, up to 20% prevalence. And then along with that, the all-cause mortality and cardiovascular mortality, again, it's like almost 3 to 4 times as compared to their non-metabolic syndrome counterparts. The waist circumference versus BMI. So this is what I was already saying, that even if the body mass index is less than 30, there is a higher risk of having an increased waist circumference. So start measuring waist circumference in your patients. And body weight has been mirrored by an increase in type 2 diabetes. So you can see that this is the data from 1990 to 1998. And as the body weight kept on increasing, the diabetes prevalence kept on increasing in those populations which were studied. Then waist circumference, and there is a risk of cardiovascular disease for each tertile of waist circumference. You can see that if the waist circumference is less than 95 in men and less than 87 in women, the first column, you can see that the relative risk is around 1 for all these. But as the waist circumference increases, the relative risk of cardiovascular disease, MI, and all-cause deaths keep on increasing. Okay, so these are the different vascular complications that are seen in type 2 diabetes even at the time of diagnosis. So the diagnostic thresholds of type 2 diabetes are developed in a way that we want to, so anything which is more than or equal to 126 fasting blood sugar would increase the risk of retinopathy. So this is how the diagnostic thresholds are developed. But there are data to suggest, this is from the hypertension and diabetes study group of the UKPDS and the UKPDS study, that even at the time of diagnosis, there were significant complications already present in those patients. And this is how metabolic syndrome comes into play, that metabolic syndrome increases these complication risk as well. So even at the time of diagnosis, there would be some people who already had retinopathy or nephropathy, as we have already seen that microalbuminuria prevalence is higher in your patients with metabolic syndrome. So coming to treatment. So really, what's wrong with eating donuts to cure obesity? Maybe there's a circle in it and less calories. So this is how your patients would try to play an ostrich approach and just want to avoid such a thing when you want to tell them that you have to reduce your weight. So what is the most effective strategy in management of metabolic syndrome? Excellent. So lifestyle modification. So you know that 500 kilocalories restriction daily equates to weight reduction of 1 pound per week. And people who are going for really brisk kind of weight reductions through different herbal treatments or through different weight reducing potions, they are basically losing water from their body, which is reducing their weight. To reduce fat, you need some time. So encourage your patients to have a gradual decline in weight, and that would result in a success later on, because if they have reduced their weight very rapidly, they would regain it. Most of the times they overshoot their original weight. So diets which are restricted in carbohydrates typically provide a rapid initial weight loss, but you cannot eliminate carbohydrate from their diets, because that then puts the body into a stage of ketosis, and which is not very good. So if they are going for a protein only diet, that should be under supervision of a qualified nutritionist alone. Adherence to the diet is very important. So we are talking about is a change in lifestyle. So they have to be cautious in whatever they are eating, and they should be exercising at least 5 times a day. So a high quality diet, like one which is enriches fruits, vegetables, whole grains, lean poultry, fish, should be encouraged to provide the maximum benefit over all the health benefits. And weight reduction includes a combination of calorie restriction that you already know, increased physical activity, and behavior modification. And for behavior modification, I think the role of clinical psychologists and psychiatrists come into play as well. So many times the patient is not understanding that what is the problems that they can develop with their weight, and maybe they are not having enough willpower to start lifestyle modification. So this is what the exercise could result. That the doctor said, I need more exercise, but he wants me to start out easy. So he is trying to take his tortoise for a walk. And then there's another doctor that is really strict in whatever he is saying to his patient, that what fits your busy schedule better, exercising 1 hour a day or being dead 24 hours a day. But I think you don't need to be such harsh